Well, good afternoon. It is my pleasure to welcome everybody in person and on the web. And before I forget, let me just say that this is the first time where we may be getting some questions live via Twitter and Facebook and all the other social media. And Susan Lair, who was just here a second ago, she's all the way back. When we come to the question and answer session, we'll be forwarding those questions to Dr. Michael Erickson, who is going to be moderating the session. So without further ado, as you can tell from as you know, that our topic today is global tobacco. And here is our beautiful globe full in smoke. And I have something else to show you. This summer, as always, I spent a couple of weeks in my old home country of Croatia, and there they haven't come to the point of showing graphic pictures, but they have come to the point of showing graphic big letters saying how dangerous smoking is, and I thought I would share that with us. So the word pušenje means smoke. So the first sign says smoking kills. Now we're talking about Europeans. So if you cannot threaten them with being killed or threaten them with dangerous diseases, you can threaten them with possibly something else. So even though this is in Croatian, I'm sure you can understand. So not to end my Croatian story on something sad, let me end it on something more beautiful. So I was trying to find an excuse to show pictures of beautiful Dubrovnik, because now I'm more and more frequently stopped in the halls by some of you who have vacationed there. And I said, what better than if any of you by any chance live on the moon and have not watched the latest episodes of Bachelorette, you would know that one of the episodes was filmed in Dubrovnik and that Jeff, with one F, did really well there. Anybody does not know what I'm talking about? Okay, good. So just as a reminder that we go back to business here, that the sessions are available for the continuing education credit, and all the information is available on the CDC Grand Rounds webpage. As always, we coordinate our Grand Rounds with our science clips, and here is the information about some of the articles that are being featured this week. We thank our experts, Terry Pehacek and Samira Asma, who have selected the articles for this week. Now, this week's presenters are Tina Fey, Eva Mendes, and Wolf Blitzer, or some incognitos who look like them. So the first of those whatevers is Dr. Joanna Cohen, who is going to be speaking on global tobacco control and the burden in the world. The second is Dr. Samira Asma, who is going to be talking about the global tobacco surveillance and why it is important. And the third one is Dr. Michael Erickson, who is going to be talking about the advances in the global tobacco control. I want to make sure that you stay tuned for a couple of sessions that are coming up. One that is going to be really interesting is high-impact HIV prevention, and I think that most of you know that there is a major HIV meeting going on this week in Washington, D.C., which is extremely important because after many years of not happening in the United States, it is happening in the United States, and there are thousands of people, some of them from CDC as well, participating at that meeting. But the other one that I'm totally excited about, which is we're going to be featuring our own Dr. House. As you can see, I am very well versed in US Weekly, In Touch, Life and Style, trivia, and things like this. So anybody here doesn't know who Dr. House is? Don't you dare. So we are going to be featuring Dr. House, our own public health Dr. House, in our September session, so I really hope you will be joining us for that. As always, when Dr. Frieden is not here in person, he is with us in spirit, And this time, he's with us in spirit in a really long version. He will be talking for almost 3 minutes because this is one of his favorite topics.
When I think of tobacco, I think of the patients I've treated. The woman with emphysema who gasped for every breath before dying a painful death. The man who was desperate to see his son graduate but died of a heart attack before he could. The man who had to live with the impact of a leg amputation from smoking. Despite recent gains, tobacco remains the #1 cause of preventable death both in this country and worldwide. Tobacco kills more people than HIV, tuberculosis, and malaria combined, and the number of people dying from tobacco is increasing. In this century, 1 billion people will be killed by tobacco unless we take urgent action. And virtually all people, not just smokers, are harmed by tobacco in some way, through secondhand smoke, environmental, and economic effects. Fortunately, we have a strategy that works. The World Health Organization recommended Empower strategy can make the difference, can turn the tide on tobacco use. Empower starts with M for scientifically rigorous and sustainable monitoring. Monitoring not just of smoking and tobacco use, but also of exposure to tobacco smoke, of marketing, sponsorship, and promotion of tobacco products, and of anti-tobacco interventions. The global tobacco surveillance system is a superb model for global surveillance, not just of non-communicable diseases, but surveillance in general, with a global collaboration for effective monitoring. This surveillance system and progress around the world provide grounds for optimism. In places where there have been comprehensive tobacco control programs, such as New York City, adult smoking has fallen by more than 1/3 and teen smoking by more than 60% in less than a decade. In Uruguay, a comprehensive tobacco control program reduced the smoking rate by 1/4 in just 3 years, perhaps the fastest decline ever recorded. Tobacco control is the ultimate winnable battle in public health, and it's one we must win. Even modest decreases in smoking prevalence would save more than 100 million lives in this century. Because the tobacco epidemic is man-made, stopping it is a critical indicator of good governance. Data from the CDC and others are crucial to document the burden, the actions taken, and most importantly, whether these actions are working. Thanks to all who worked on these presentations and to all who work on tobacco control. Your work is crucial. Millions of lives are at stake. Thank you.
Hi. Well, thank you very much. Good afternoon, and thank you, Tanya, for that very unique introduction that I will never forget. My name is Joanna Cohn. I'm with the Institute for Global Tobacco Control at the Johns Hopkins Bloomberg School of Public Health. I'll just go back for a moment. Thank you. Over the next few minutes, I'm going to provide, here we go. We're set. I'm going to talk about a profile of the extent of tobacco use on a global scale. I'm going to discuss the burden caused by tobacco products and what we can expect in the future. I will address the critical role of the tobacco industry in this pandemic, and I will set the stage for Dr. Erickson's presentation by highlighting that we do have solutions to combat tobacco use. Tobacco is used in many different ways around the world. Manufactured cigarettes are the most commonly consumed product, accounting for 96% of worldwide tobacco use. The next most popular products are BDs that are used in Southeast Asia, various forms of smokeless tobacco and chewing tobacco used in India, and Kretex that are used in Indonesia. And of course, new forms of nicotine and tobacco are constantly being invented. This image and much of the data in this presentation are drawn from the 4th edition of the Tobacco Atlas that was published earlier this year. The Atlas is an invaluable resource for statistics and information on the tobacco pandemic, and you can find it online at tobaccoatlas.org. Now, the numbers I'm going to provide over the next few minutes are absolutely staggering. But unfortunately, these colossal numbers are what we have to face in the tobacco pandemic. So over the 20th century, global consumption of cigarettes increased by over 100-fold. And in 2009, over 5.8 trillion cigarettes were consumed. The top 5 cigarette-consuming countries in 2009 were China, the Russian Federation, the United States, Indonesia, and Japan. More than 1/3 of the world's cigarettes were consumed in China that year, and only 11% of the global cigarette consumption occurred in the Americas. Now, about 800 million men smoke cigarettes, and there are 14 countries where 50% or more of men smoke. Male smoking prevalence is highest in Greece, Indonesia, and the Russian Federation, while countries with the highest number of smokers include China, India, and Indonesia, despite the fact that 10 times more men smoke in these countries than women. Nearly 200 million adult women smoke cigarettes. Female smoking prevalence is highest in Austria, Greece, and Bosnia and Herzegovina, while the highest number of female smokers are in the United States, China, and the Russian Federation. The good news is that more than half of all countries have a female smoking prevalence of less than 10%. Now, we're concerned about tobacco products because they are extremely harmful to health and they damage every part of our bodies. The 4 main non-communicable diseases, which are cardiovascular disease, diabetes, cancer, and chronic lung diseases, kill around 3 out of every 5 people worldwide, and they cause great socioeconomic harm, particularly in developing nations. And as you can see, tobacco use is the only risk factor shared by the 4 major non-communicable diseases. Tobacco use is also a risk factor for 5 of the 8 leading causes of death in the world. Now, as I said, the numbers are practically incomprehensible when we look at the burden of tobacco products. They were responsible for 100 million deaths in the 20th century. Tobacco use is now the world's single leading preventable cause of death. And as Dr. Frieden said, it kills more people than AIDS, tuberculosis, and malaria combined. And unlike these other major killers, the number of deaths from tobacco products are increasing. Globally, tobacco is currently responsible for more than 15% of deaths among men and 7% of deaths among women. And in 2011, tobacco products killed almost 6 million people. They kill from 1/3 to 1/2 of people who use them, and smokers die an average of 14 years earlier than non-smokers. Now, the US Surgeon General has clearly stated that there is no safe level of exposure to secondhand smoke. An estimated 600,000 people died from this exposure in 2011, with 3/4 of the deaths from exposure to secondhand smoke among women and children. So, in essence, men smoking is killing women and children. From 2000 to 2004, cigarettes were responsible for an estimated $193 billion in annual health-related economic losses. This includes $96 billion in direct medical costs, and nearly 5% of US healthcare expenditures were spent on treating tobacco-caused diseases. Now, if current trends persist, an estimated 500 million people alive today will be killed by tobacco, and tobacco will kill more than 8 million people worldwide each year by the year 2030. By the end of this century, tobacco may kill 1 billion people unless urgent action is taken. And it's critical to keep in mind that each and every death from tobacco products is completely preventable. Now, shortly, I'll introduce proven public health strategies to reduce tobacco use, and you will hear more details later in the session. But before we discuss this solution, we need to understand what is fueling the tremendous harms that I've just described. For an audience familiar with the epidemiologic model of infectious disease transmission involving the host, the agent, the environment, and vector, by analogy, the tobacco industry is a vector for tobacco-caused diseases, responsible for putting the agent, in this case the tobacco product, in contact with the host. Now, tobacco is grown in 124 countries. China produces 43% of the world's tobacco, with a 200% increase in production over the past 30 years. The other leading producers of tobacco leaf are Brazil, India, the United States, and Argentina. And though not included in this figure, Malawi and Indonesia are also major producers. Now, tobacco farming negatively affects the environment, predominantly through deforestation. Tobacco farmers are also at risk of green tobacco sickness due to contact with nicotine in the tobacco leaves, as well as neurological damage through exposure to pesticides. And their children are also at risk, as they often assist their parents with the cultivation and curing of tobacco. In addition, tobacco growing is a contributor to undernourishment, as it reduces the amount of land available to grow food. 5 companies command over 80% of the global cigarette market share. The China National Tobacco Company, which happens to be the largest state-owned tobacco company, produces more cigarettes than any other company in the world. It's responsible for more than 1/3 of cigarettes sold worldwide. In 2010, the combined total revenue of the top 6 tobacco companies was over $346 billion. Combined profits of these leading 6 tobacco companies was $35 billion, which was equal to the combined profits of Coca-Cola, Microsoft, and McDonald's that year. $35 billion in profits works out to nearly $6,000 in profit for every death caused by tobacco products. Now, despite increasing restrictions on marketing, tobacco companies continue to spend billions of dollars each year on advertising. In 2008, $9.9 billion was spent on cigarette advertising and promotion in the US alone. And this amount is more than $34 spent on tobacco marketing for every man, woman, and child in this country. In the US, 83% of tobacco companies' marketing budgets are spent on price discounts, coupons, and retail value-added promotions. In general, in the US, tobacco companies spend almost twice as much on marketing as the junk food, soda, and alcohol companies combined. Now, beyond the direct marketing of tobacco products, the tobacco industry can exert broader influences on society. In addition to direct political influence to shape public policy and legislation, tobacco companies make charitable donations, many under the guise of corporate social responsibility. These contributions are not only a form of tobacco advertising and promotion, but they also allow tobacco companies to legitimize themselves with policymakers and the public and counter the negative attention surrounding their products. To help countries combat the unnecessary death and disease caused by tobacco products, the World Health Organization developed a policy package to reverse the tobacco epidemic called Empower. There we go. And as Dr. Frieden said, M represents monitoring tobacco policies, programs, and tobacco use. This is the area that CDC has focused much of its global contributions and through the leadership of the Global Tobacco Surveillance System, which you will hear about shortly. P represents protecting people from secondhand smoke through smoke-free public places. O is for offering help to people who want to quit. W is for warning people about the dangers of tobacco products through mass media campaigns and warnings on tobacco packaging. E relates to enforcing regulations on tobacco advertising, promotion, and sponsorship. And R is for raising taxes on tobacco. This is the intervention most certain to reduce tobacco consumption. So finally, because low and middle income countries are still in the early stages of the tobacco epidemic, they have yet to experience the full impact of tobacco-caused disease and death, already evident in wealthier countries where tobacco use has been common for most of the past century. And many of these countries have fewer resources to respond to the health, social, and economic problems caused by tobacco use, which will exacerbate the tobacco epidemic's impacts. Tobacco-caused death and disease will hit these countries very hard in the coming decades, absent a strong international effort to combat tobacco use. Dr. Erickson will soon describe the great strides that have been made by many countries to address this preventable epidemic. But first, it's my pleasure to introduce Dr. Samira Asma, who will tell you about the global tobacco surveillance system.
Good afternoon. My name is Samira Asma, and I'm the chief of the Global Tobacco Control Branch at the CDC. I will be talking to you today about the global tobacco surveillance system. So the global tobacco surveillance system is a set of globally standardized surveys. It allows us to monitor not only the problem, but also the solution. GTSS enhances countries' capacity to design, implement, and evaluate tobacco control policies. An important global effort is the Article 20 of the WHO Framework Convention on Tobacco Control. You will hear about it more from Dr. Erickson. I'm mentioning it here because among its recommendations, this article highlights that surveillance should be an integral part of the tobacco control strategy for each country, and in a way that data is comparable and can be analyzed at the regional and international levels. Our global tobacco surveillance system enables the countries to fulfill their obligations to the WHO FCTC. The global tobacco surveillance system comprises both youth and adult surveys to monitor tobacco use and track key tobacco control policy measures. And these are the Global Youth Tobacco Survey, the Global Adult Tobacco Survey, and the Tobacco Questions for Surveys. I will be sharing with you some examples of the key findings from each of these. The Global Youth Tobacco Survey began in 1999 and is the largest public health surveillance system ever developed and maintained. It is a school-based survey of students aged 13 to 15. It is a self-administered survey and has been conducted at least twice in all the countries pictured in blue. The survey has been repeated even 3 or 4 times in several countries, generating trend data and providing systematic and consistent comparisons across and within countries over time. Here are some important survey findings from the Global Youth Tobacco Survey, and let me just highlight a few. 1 out of 10 students currently smoke cigarettes. Smoking often begins by age 10, and that most students, smokers, want to quit. The Global Adult Tobacco Survey, launched in 2008, is a nationally representative household survey of adults aged 15 years and above. It is being implemented in 13 countries, completed in 18. To date, the survey covers 66% of the world's population and represents 68% of world's smokers. As Dr. Frieden mentioned, this survey has emerged as the global standard to track tobacco use and key tobacco control policies. Here are some basic statistics for the 14 countries for which I will be presenting the results. 1 million household-level data have been collected. More than 300,000 surveys have been completed in nearly 50 languages and dialects. Almost 3,600 field workers have been trained, using nearly 3,000 handhelds and completing 1,500 field work days. More than 65 million data points collected, representing 3.6 billion people, over a half of the world's population. GATS uses a core set of standard protocol that includes questionnaire, sample design, and a series of manuals and guidelines. The expert review committees provide rigorous scientific and objective reviews, and electronic data collection methods improve efficiency and quality of data. Again, we have a lot of interesting findings, and let me highlight just a few. Results from GATS include 794 million adults currently use tobacco, 350 million exposed to secondhand smoke at workplace, 5 in 10 current smokers plan to quit or thinking about quitting. Now, I will present some selected results linking the global adult tobacco survey data to Empower, introduced to you by Dr. Cohen. For example, for Monitor, we have tobacco use prevalence by gender. The ratio of male to female tobacco users varies widely across countries, from a low of 1.5 in Poland to a high of 63.5 times in Egypt. And now let's take a look at the exposure to secondhand smoke at workplace, with China being the smokiest workplace and Uruguay being the most effective in protecting its workers. This graph shows the percentage of people who have quit smoking. The two countries with highest proportion of quitters are Brazil and Uruguay, both having implemented comprehensive tobacco control policies. I would like to draw your attention now to those who thought of quitting because of a warning label on cigarette packages. For example, Brazil has one of the most effective health warnings labels where 65% of smokers thought of quitting. And Dr. Erickson will provide more details on the impact of Brazil's health warnings. We know only a few countries have implemented point-of-sale advertisement bans. Only 4 of the countries, Egypt, Thailand, Turkey, and Vietnam, have these bans. And in these countries, we notice relatively low levels of exposure to cigarette marketing in stores. We also track price and affordability of tobacco products in the surveys. The cheaper the products, the more affordable they are. Countries with higher bars on this chart are ones where cigarettes are less affordable. For countries that cannot implement or participate in standalone tobacco surveys, Tobacco Questions for Surveys offers countries an opportunity to simply insert a set of standard questions into their ongoing surveys, such as the non-communicable disease risk factor surveys or the demographic and health surveys. Anywhere from 3 to 22 questions can easily be added to promote standardization and comparability. The map shows countries where this has been done, and I will just show you an example from Bangladesh. Bangladesh implemented a standalone survey, that is GATS, in 2009, and a multi-risk non-communicable disease risk factor survey in 2010. And here we can see from the data, the results are comparable for specific age categories from these two surveys. Here is our interactive web page, and as you click on this world map, it takes us down to a region. We can zoom to a region that is Southeast Asia, and further, you could click on to a country, in this case, India. Further clicks would offer you further in-depth data points by states. And finally, you can access data from various surveys. Also available are reports, data sets, and fact sheets. And one can track data by country as well as by Empower indicators. In conclusion, data from the global tobacco surveillance system provides unprecedented cross-country comparisons and tracks not only the problem but offers solutions. The system embodies the saying that what gets measured gets done. Now I would like to introduce our next speaker, Dr. Michael Erickson.
Thank you, Samir, and it's a great pleasure to be here. 20 years ago, I joined CDC as Director of the Office on Smoking and Health. And in the 10 years that I was here, two of the best things I did was to recruit Samira to CDC from WHO and Terry Pahacek from Roswell Park to the Office on Smoking and Health. And it's great to see many friends and colleagues here today. What I want to do in my few moments is to talk about some of the good news, some of the progress that's been made, and also some of the progress that still has yet to occur. The good news really is that there are effective and proven strategies for reducing tobacco use, and that to the extent that we can implement these actions, it's estimated that we can save up to 100 million lives over this century. And that can be achieved specifically by achieving a global reduction in prevalence from 25 to 20%. And this was published by your CDC Director Frieden and Mayor Bloomberg in Lancet in 2007. Much of the success and the evidence regarding what works in tobacco control has been published, much of it by CDC itself. You can see in the documents Surgeon General's reports going back to 2000, best practices, which originally came out in 2000. It's been recently updated. The Empower report that you've heard a lot about, NCI reports, IOM reports. There's no shortage of information that documents what can be done, and what I will be talking about and kind of reiterating what's already been said, it comes down to a few strategies. One, certainly increasing the price of tobacco products, which decreases the youth and adult smoking, implementing smoke-free policies that protects non-smokers from secondhand smoke, and as well as changing social norms, comprehensive ad restrictions, if not bans, which reduce tobacco's appeal, aggressive media campaigns to both prevent initiation and encourage smokers to quit, and cessation efforts that can help smokers quit. And as you saw in some of the data that Samira presented, for instance, in the United States there are more ex-smokers than current smokers, but in China and many other countries, little over 10% of smokers have quit. So there's much that can be done. You've heard a lot about Empower, and I won't go through it in much detail, but to emphasize that the Empower takes the purpose of this is to take those things that we know works, such as R from raising taxes, and P for protecting people from secondhand smoke, and adds to that the interventions, adds a very much of a CDC dimension of monitoring. So it specifically puts in monitoring and surveillance as one of the key elements of advancing global tobacco control. I did want to say a word about the Framework Convention on Tobacco Control, which you've heard about as well. This is the world's first public health treaty. 176 countries around the world have ratified it. The Framework Convention really is a framework of getting global agreement on the types of things that need to be done, very much consistent with the Empower strategies, such as tax increases, advertising bans, clean indoor air laws. But a lot of the specifics is reserved for protocols, which are then negotiated and ratified separately. So that's kind of the structure of the Framework Convention. The sad news is that 3 of the major tobacco-producing and consuming countries in the world have not ratified the Framework Convention, specifically Argentina, Indonesia, and sadly, the United States. Some of the areas that we have seen success globally and recently is particularly in protecting smokers from involuntary exposure to secondhand smoke. This is a phenomenon that really began in the early 1980s in California, extended throughout the United States, and is now diffusing throughout the world. And the number of areas that are smoke-free has really doubled between the time between 2008 and 2010. And this is one of the most rapid areas for progress in tobacco control, and one that not only protects non-smokers, but also helps to change social norms. And you can see from this slide, there's great public support for comprehensive smoking bans, in this example for bars and restaurants, after they've been implemented. Many cases, even smokers are supportive of smoke-free environments, and this is the case whether we're talking about New Zealand or New York City. As I indicated, the smoke-free clean indoor air laws have multiple benefits of, first and foremost, protecting the non-smoker from harm, but secondly, it also helps smokers quit and cut down, as well as changing the social norm. And in this country, and any of you, I'm sure, can remember the time when smoking was allowed in airplanes. And when we thought about banning smoking in airplanes, it was unheard of. And now today, when if someone were to light a cigarette in an airplane, you can imagine the reaction that would occur. And that's a change, a dramatic change in norms that's occurring throughout the world. The next area that, just to mention, where a lot of progress is occurring is in terms of pictorial or graphic warning labels. And you, again, heard this mentioned earlier. This data is from Brazil that shows half of those surveyed changed their opinion about the health consequences of smoking. Close to 70% of Brazilian smokers said they wanted to quit as a result of the labels. And there was widespread approval for these labels. To be effective, these warning labels must be large, with dramatic images, include specific warnings. They need to be changed periodically to stay fresh, and to make sure that deceptive terms such as light and low tar are not allowed. This is an example of the next step in the warning label process, where in Australia they're introducing plain packaging. And plain packaging goes beyond simply having graphic warnings and statements. It also takes away the imagery that's associated with the color and brand appeal that comes from a pack of cigarettes. Australia passed a law to have plain packaging that will take effect December of this year. This is an example of one of the Australian packs. And needless to say, the tobacco companies are concerned. They've sued, and the regulations are on hold pending judicial review. In fact, the tobacco companies have encouraged other countries to file complaints with the World Trade Organization against this action. And it'll be very interesting to see whether trade or public health wins out. The last graphic on warning labels is just to emphasize where progress is occurring. The countries, the darker red, the color of the country, the more explicit the warning labels they have. In the United States, we should mention that the FDA has proposed bigger, stronger warning labels with graphic images on the top half of the front and back of a pack of cigarettes. But again, the U.S. regulations are pending, subject to legal challenges by the tobacco industry, if you can believe, on First Amendment basis, that this having warning labels is a violation of the freedom of speech for the tobacco companies. Let me just say a word quickly about marketing bans. Many of you know that cigarettes are inherently unappealing the first time you smoke it, that you try to smoke it because it's made to appear to be glamorous and sophisticated. And many countries are restricting, if not banning, the promotion of and advertising of tobacco products. We have data showing that when a country has a comprehensive ban on all aspects of tobacco advertising, marketing, and promotion, it's associated with a large decrease in consumption compared to countries without a ban. The tobacco companies, obviously, again, fight these types of restrictions, and in our country, again, claim it under the commercial freedom of speech to continue to advertise what is otherwise considered to be a deadly and addictive product that is the leading cause of death in our society. Probably the single most effective way that's known to reduce tobacco use is to increase the price of the product. Price affects consumption for all consumer products, with the exact amount expressed in terms of an elasticity coefficient, which basically for smoking is that for every 10% increase in price, there's a 4 to 7% decrease in consumption. And here's some examples from around the world for both South Africa and Morocco. The countries, the Framework Convention and Empower recommend that tax is about 75% of the total price of a pack of cigarettes, and a few countries have reached this. But whilst countries are increasing the price of tobacco, oftentimes it's not sufficient to keep up with inflation, and where the red dots on this map are examples of places where the price of tobacco products is actually decreased between 2002 and 2007. I think Samira mentioned that GATS is measuring affordability. She presented the data by country. This is a look at affordability by region. And despite our desire to increase the real price of tobacco products, the affordability of tobacco products, which is again measured in terms of per capita income needed to purchase 100 packs of cheapest cigarettes, has actually, smoking has become more affordable everywhere in the world except for Europe. And there's no data on Africa. So cigarettes are becoming more affordable rather than less affordable. And then the last major point I want to touch upon in my few minutes is around funding for tobacco control. Governments around the world collect $133 billion in tobacco excise tax revenue. There's also other types of taxes that are collected. But most of this, or very little of this, is spent on tobacco control. And what is spent on tobacco control tends to be spent in the high-income countries. So in many ways, countries have an addiction to tobacco products in terms of revenue in a way similar that individual smokers are addicted to nicotine. But we have made progress. That most of this progress has occurred in the last few years. The blue lines, or the violet lines here, show an increase of coverage of the Empower categories, and you can see that the greatest progress has occurred since 2008, where there's really been a major effort undertaken both by WHO with Empower and the Framework Convention globally. Let me just conclude by saying that the problem caused by tobacco use is really unprecedented in scope and preventability. We need to have data from multiple perspectives to fully understand and prevent the epidemic from continuing. And to address this need for data, we've been monitoring all of the factors that contribute to the tobacco problem through the publication of the Tobacco Atlas, which is now in its 4th edition. And much of the data you've seen today has come from the Tobacco Atlas, and it's online at tobaccoatlas.org, and we'd be pleased to make copies available to anyone who would like it. In conclusion, we know what to do, and we simply must gather the will to do it. As been pointed out today, the problem caused by tobacco is immense, without parallel, and yet entirely preventable. The vector is human, it's driven by profit and the disregard of public health. The solutions are also human and should be driven by fairness and equity. And with that, I'd like to conclude, and we've opened this up for questions from the audience here and online. Thank you. So if there's a question in the room or online, we'll take one from the room first, if it's possible, while they get the online and Twitter feed. Ann?
Sure. This is Ann Schuckett from NCIRD. Thanks so much for a fantastic session. You know, I loved your infectious disease model, and I wanted to ask a question about the vector. In particular, I was very interested about the size of the Chinese tobacco production and that it's state-owned. And I wondered whether the field is looking at opportunities with a political influence there to try to, you know, repurpose that government industry for something else. I mean, it just seems like it's such a huge central piece of where the action is. So comments from the panelists would be welcome on that.
And this was specifically regarding China? Okay. Joanna, would you like to?
I mean, you've, you know, put the nail on, you've named exactly the major problem in China, and I think, I'm not sure if I mentioned it in my comments, but I think it's 7% of China's GDP is coming from tobacco. So it's a major problem. It's interesting, though, in a broader perspective, because a number of tobacco control thinkers around the world are talking about the end game and how do we really deal with the vector, and what sort of system would serve public health goals. And interestingly, one of the propositions put forward is some not exactly like the China tobacco monopoly, but some sort of national oversight of tobacco sales with specific incentives to reduce sales, actually, and high penalties when sales don't reduce. So there's some interesting models being thrown around. I don't think there's consensus yet on what the best approach would be.
I would just add to that, I spend a fair amount of time in China, and it is complex and intimidating in some ways, but it was that way here 20 years ago as well. When I took over as director of the Office on Smoking and Health, while we did not have a monopoly of tobacco within the government, in effect we had control by the tobacco industry of government in terms of expenditures and policies, and that has changed dramatically over 20 years. So I do think change is possible, and one thing about China is China changes very rapidly. It's a very dynamic country, and it's complex, but they realize that tobacco and revenue is a two-edged sword in terms of health costs as well as in terms of revenue. So it's exciting and challenging, but not necessarily impossible. Yes, sir.
Yeah, thanks for a great presentation. Ann's question was about the Chinese government. There were a few comments made in the presentation. I'm curious about our own government.
Jordan, you will have to use the microphone for the external audience, please. Just sit into somebody's chair.
I noticed the great progress that has been made in bars and elsewhere, but we're not a signature of the treaty. And secondly, what is our support through Congress that's ongoing for our tobacco industry? Thank you.
Technically, and I won't ask Samira to comment. I'll save her the issue. But Joanna can certainly. Yeah, the U.S. is a signatory, and there's a distinction between signing the treaty versus ratifying it. So the U.S. government did sign it, but it has not been presented to the Senate for ratification. Right. Just to be technically clear, I think in my observation, there's been a lot of progress. With FDA regulation, tax increase in recent years, but there's still so much more to do. We're very excited that in 18 months, or whatever, there'll be the 50th anniversary of the Surgeon General's report from 1964, and that will be a chance to really observe the type of progress that's happened in this country. My observation is that most of the progress that's occurred has really come at the local and community level, and then some at the state level, and perhaps less at the federal level, as opposed to other countries that are a little bit more aggressive federally. But we certainly, if you look over the change that's occurred, the smoking rates have been cut in half, consumption's been cut in half, and still we're only halfway there. Joanna, do you want to add anything? I would just add, I mean, this is all, the fact that the FDA is being sued for implementing a law passed by Congress to have warning labels on packs, I think characterizes the nature of the environment that we're in, that even when you get congressional action, it's not automatically implemented because of the way the industry knows how to delay, and that's the strategy that they've used for decades, is to delay meaningful action.
And actually, maybe I'll just add to that. Dr. Erickson mentioned plain packaging in Australia. It's actually not just plain packaging, it's plain and standardized packaging. So even the same size and shape of packages, because of course the companies can innovate on those aspects as well. But it's just recently that Australia has passed that legislation, and the tobacco companies intimidated other countries 20 years ago that were talking about implementing plain packaging at that time. So it's not just in this country, it's around the world that they use these tactics to scare countries from doing what's right for public health.
Any questions online?
Yes, we have several online. We have a question directed to Dr. Asma from a military hospital in Kuwait. It says, looking back as tobacco industry is under pressure in the West and the consumption is decreasing hand in hand with the bad effects of tobacco, personally, he refers to the success to the empowerment of non-smokers, rather persuasion of smokers themselves. Is he right? And in the thin possibility that he is, how can we transfer this policy to the East?
Very good question. Thank you. I think the social norm change is key for bringing down reductions in tobacco use. And whether smokers or non-smokers, I think what is being promoted through the WHO Empower policies is a comprehensive package that would address all populations alike. So I think implementation of those would be key.
Thank you. Our next question comes via Twitter. At what point will raising taxes drive consumers to black and gray markets, defeating enforcement efforts?
Well, the raising taxes will drive people to other black markets and smuggling and counterfeit cigarettes and tax avoidance to the extent that that's allowed by government. When governments realize they lose a lot of revenue from smuggling, they will enforce the tax laws as they do across the board in other areas. The real secret to this is having more uniform national tax policy as opposed to the differences by state. For instance, in Georgia, we now have our taxes the 48th lowest in the country at 37 cents. And I'm not facile enough to know what it is the highest, but it's probably like $1.50. Someone probably knows. 420, or just the state tax? New York State. So tenfold difference by state, and that phenomenon certainly doesn't help the issue of cross-border sales or other ways. So, and I think it's great that the current administration did increase the tobacco tax by $1.01 fairly recently to help support child's health insurance. And so that was a very positive move.
We have another question for Dr. Erickson. Okay. That you were working on tobacco control in China for a long time. And this person is wondering whether you or other panelists have any comments, the effectiveness of smoking cessation among the Chinese population, and any studies that have been done to assess the cost effectiveness in China, as well as potential hurdles for implementing this proposal.
I would just say that smoking cessation basically doesn't exist in China, that people smoke and die. They die of smoking. And what has to happen is there has to be role models to demonstrate that you can quit, that quitting is achievable, desirable, and I personally don't think that's going to be achieved through pharmaceutical interventions, but rather through public health interventions about clean indoor air, increased taxes, changing social norms. There are more smokers in China than people in the U.S., and clinical interventions and pharmaceutical interventions it's not going to be very cost effective to reach 350 million smokers clinically. So we need to have population interventions. Joanna, do you want to add, and then we'll, great. Tanya?
And thank you very much for coming. I do want to point out that this is the first time we have been getting questions directly from our social media. And I also have to say that while I'm very well versed in who is dating who in the movie star world, I was letting our deputy director know that this is the first time we are Twittering, and she says we're tweeting. So just, she's up on this one, and I have to be corrected. Thank you very much. See you next time in our usual place, Auditorium A. Thank you.